So we're finding that the quality of the care that we provide is better, the coordination of the care is better. We can spend less time retrieving medical history and more time working on the relational aspects with the client. There's really no point in us spending time getting a medical history from someone who has their medical history written in 5 places already. So it expedites some of the behavioral health work that we're trying to do and certainly helps build the alliance with the patients.
It's improved our work, our ability to connect with clients, with other providers, to provide a more cohesive service, to connect with medical providers and other hospitals. It's also allowed us to intervene at times that previously we would not have been able to intervene because we wouldn't have even known anything was happening with a client.
So we were able to look into the emergency room report. You could follow him along as he went through the emergency room from his presenting problem, which he actually presented to the emergency room while his hip was broken as suicidal. That was his chief complaint, which was interesting to see, because that wasn't really the problem. I mean, he was actually in excruciating pain, but was unaware that the fall he had was resulted in the broken hip. So from that, we were able to see that he, had his labs drawn, and we were able to see the radiology report that there was in fact a fracture and that he was scheduled for surgery. So this allowed our team to contact the hospital, explain that his follow-up care is already in place, so it's not something that they would need to spend time constructing or creating, and it allowed us to coordinate the care and be prepared for his discharge well in advance of any of that happening.
We met with him several times in the shelter, and eventually we lost contact with him. He was not in the shelter. He did not have a phone. We did not know his whereabouts. And then we received a notification that he was in our emergency department with frostbite. And so we were able to intervene. He ended up needing an inpatient hospitalization. We've re-engaged services with him. We're working on housing with him. We've actually found some family supports. Our case manager has reached out to some family supports that actually are starting to re-engage with him as well. So he's doing better. It was a very unfortunate situation, but we are able to kind of wrap services around him.
We looked into the patient portal and we saw that he was receiving Suboxone from a provider. He was also receiving psychiatric medications from a different prescriber, as well as the medications from us. That helped us basically help him. It was sort of through an unfortunate circumstance where he had overdosed. And when we looked into the record for the ER, we saw the prescriber's name and the medication that he was prescribing. So our psychiatrist contacted that psychiatrist. That psychiatrist alerted us to look even further in to see that he was in fact also receiving the Suboxone from another provider. And this allowed us to really sort of prevent a duplication, or in this case, a triplication of the prescribing practices, and certainly improve the quality of his care.
One Monday came, he didn't show up. Tuesday came, he didn't show up, and people were starting to talk about discharging him. Lawyers were calling saying he was going to go to jail. We used Health InfoNet to find out where he was. He was outside of our system in a medical hospitalization for a very appropriate reason. So we were able to with his permission, provide that information to his lawyer so that that prevented his incarceration, and to our outpatient providers so that they did not discharge him. After he was discharged from the medical facility, he re-engaged with our outpatient services, and he did not go to jail. So he's still engaged with outpatient services now, and this is one of the longest times that he's been free of incarceration or inpatient hospitalization.
So what we have now is an arrangement with the clients. We know what day they're supposed to get their labs drawn. We should then be getting the notification from Health InfoNet that shows that they got their labs drawn. If we don't receive it, then we know we need to call the client and say, we don't have any indication that you received your labs, and that's going to create a problem tomorrow. We won't be able to dispense the medicine for you, so we really want you to get your labs. Do you need us to help you get to the lab? Do you want us to take you? And it really is a nice way to look at how Health InfoNet allows us to prevent problems and to better coordinate the care.